Hi everybody, I'm Amanda Tanhchaleun, and my DNP project will involve the management of steroid-induced hyperglycemia in oncology patients in the inpatient setting at the Queen's Medical Center. This issue initially stemmed actually from an email that was sent from two physicians out in the MD Anderson Cancer Center in Texas. They reached out to the Queen's Medical Center diabetes team for advice on management of hyperglycemia seen in their cancer patients who were receiving chemo with or without steroids or steroids as part of their treatment. They were noticing hyperglycemia even in patients without pre-existing diabetes. So they asked Queens if what we were doing, if we had some sort of management protocol in place, and unfortunately, but fortunate for me, we don't have one at Queens. There's no protocol on glucose monitoring when steroids are initiated, no steroid-induced hyperglycemia algorithm at this time. As we all know, with steroids, there is a slew of negative effects, one of them being hyperglycemia. And hyperglycemia is associated with prolonged hospital stays, increased incidence of infection, disability after discharge, and even death. So just imagine these oncology patients who are already immunocompromised, and then you tack on that steroid, give them some hyperglycemia, and they just are at an even higher risk of complications. So this just emphasizes the need for appropriate and prompt treatment of that hyperglycemia. So my plan is to initiate an order set that will automatically populate with any new steroid order for these oncology patients. So this order set will involve automatic glucose monitoring for at least the first 24 to 48 hours of steroid initiation. That way we can catch hyperglycemia early on. If the sugar remains greater than 140 for an X amount of times, the nurse will be able to follow some sort of algorithm that I will be creating that will first off start with consulting the diabetes team to quickly initiate appropriate management. But enough about DNP. Let's see. Leadership experience. Probably my most valuable leadership experience was being appointed as the MedSurg Tele Float Pool Unit Council Chair. I was sort of voluntold to do it, but I'm thankful now that it happened. I had less than a year of experience under my belt, so I was naturally nervous, anxious, scared of rejection of any of my ideas, just inexperienced, just like how I feel now about the DNP project. But at the same time, I did feel, as I do now, excited and motivated to take on the challenge and just create a change for the better. Probably two of the most valuable leadership qualities that I gained from this experience is one, being resourceful, and two, being flexible. These two qualities will definitely help carry me through the DNP project, hopefully. So being resourceful is key because with lack of experience, we're going to need to work with different lines of service. So IT, nurse managers, nurses, physicians, and it is important to know your resources and who to call when you need help and not be afraid to ask for that help as well. Because it will definitely need a multidisciplinary approach to be successful. Being flexible is also key because we are proposing a change to these busy health professionals who already get change thrown at them at all angles, from their managers, from patients, from technology, etc. But so tacking on our initiative that we hope will be for the best can be stressful and may be met with some pushback, some rejection. So just being flexible, having a plan A, B, Z, just in case, and knowing that there will be bumps along the road, but can be resilient through being flexible. So thank you for listening to my spiel. Good luck, everyone.